Hello and welcome to The Connection, where RLDatix's Chief Customer Officer Liz Jones and Medical Director Darren Kilroy are joined by leaders and colleagues from within the healthcare industry. In The Connection, we explore how people and technology in healthcare can come together to create great experiences and support patient safety. We hope you enjoy listening.
Hello and welcome to this edition of The Connection, where myself, Liz Jones, and my colleague Darren Kilroy will be joined by Helen Hughes from Patient Safety Learning. In The Connection, we explore how people and technology and healthcare come together to create experiences and support patient safety. So, Helen.
Hello. Yes. Fantastic. Thank you very much for inviting me. And it sounds like a really interesting series.
We're exploring. We want to really think about people and their roles in healthcare. We want to understand your background in patient safety and where you think that has got a really important role with technology generally across the health systems. I think to kind of understand your point of view, it's best to understand a little bit about your career and why you find yourself now in the role of chief exec of an organisation that's really galvanising a movement around patient safety globally.
It is. It's Patient Safety Learning's only been going 5 years, and now it's particularly with the Hub, our free knowledge learning platform. We're global, so 40% of the people that access that are international. My involvement in patient safety is a comparatively unconventional one, and I don't often say this, but obviously if it's podcast, a lot more people will know about it. I got into it in my role as finance director in the NHS. And I distinctly remember sitting at a table reading Organisation with a Memory, which was Sir Liam Donaldson's report in about 2000, and going, yes, light bulb flashy moments. Because I'd been heavily involved in corporate governance and really committed to healthcare. I wanted to work in healthcare. I wanted to take a leadership role. I wanted to support the delivery of safe and effective services and actually making sure that the health system responded to preventing ill health as well as responding with care and treatment of people that needed it. And so that was my vision and my passion for getting engaged. And I had some skills in finance, so that seemed quite good because if you're a finance director, you've got money and money equals power. So I thought I could influence change. So I moved from kind of provider trust organisations to what was then health authorities, moving up the kind of system and then working at a national level and across the region in London, a number of initiatives. But there was this parallel world where you'd got clinical governance on one side and corporate governance on the other side. And Liam Donaldson's report, expert report, followed on from To Err is Human, which was the first really big report from the US, highlighting that we needed to combine those. We needed a systematic approach to healthcare and that just everyone working in silos just doesn't work as effectively. And that's the lessons from other industries. So it's applying them in healthcare. So I read that and thought, that's it. That's what I want to do. So that's how I kind of switched my career, worked as the Director of Operations of the National Patient Safety Agency, and then went on to work with Sir Liam at the World Health Organization, setting up that global program, and particularly getting engaged, range of issues, but the patient engagement and the patient perspective as a kind of part of a societal change in looking at patient safety in a different way. And then when I came back to the UK for personal reasons, I did a number of roles that were social justice, but not directly patient safety, but kind of linked to that whole world. So I was a number of roles, including Chief Exec of the Equality and Human Rights Commission. I led for the then Ombudsman at the Parliamentary Health Service Ombudsman, but always a passion to get back into patient safety and to do my bit to raise awareness, share knowledge, and to help people do the best they possibly could using the insights from when things go wrong and when things go right.
So it's interesting that, Helen, because from my perspective as a clinician for years, just be interested in your thoughts on it. It sounds like it's semantics, but to me it's not. How you differentiate between patient safety and clinical safety, because in my clinical life, and this was some years ago, hard to believe, but some years ago, we're very focused on the technical elements of the procedure and making sure we've got good quality outcomes in terms of the joints correctly inserted or the wounds beautifully stitched or whatever. But there wasn't much thought around the wider safety agenda. So for me, it was all focused around clinical safety, clinical outcomes. But patient safety is something different. Could you explain to us what the difference is, why that matters?
There are lots of different opinions on this, and I wouldn't say I'm the most expert, but I'll give you my perspective. And it was something I was asked to Clive Flashman, our Chief Digital Officer, and I helped coordinate, and it was chaired by Sam Ashar, this expert group on EPR implementation and safety recently. And Clive asked me to start, and it was a closed private group, but asked me to start to make that distinction. And it occurred to me that a lot of the people in the room, and possibly those that had a clinical background, wouldn't quite understand the difference. Surely it's the same thing. And of course, patient safety encompasses clinical safety, but patient safety, in my sense, is a broader kind of system safety. So, it's, say if you're a clinician, I don't know, let's pick the obvious one of a surgeon or part of a surgical team. It isn't just having the knowledge, the procedures, the resources in front of you, the staff, the right patient, understanding what the right procedure is. You've got to have the right packaging and labelling for the products if you're getting a prosthetic device. You've got to have the right physical environment. You've got to have the right lighting. You've got to have the right working conditions. So if you're exhausted, if you're trying to do too much, if you've got the wrong patient on the wrong list, if you haven't got all the safe surgery checklist requirements, it's a much wider organisational issue. And then you've got the themes of, if you've got an operating department practitioner goes, hang on, I see there's a risk there. Shall I speak up? Last time I did, I got, bawled out. Yeah. I'm not going to do that. Then you've got a culture and an environment where you're not getting people to speak up, or you're not being listened to, if you haven't got the right leadership. So it's all those conditions that enable clinicians to do their great stuff. Sure. If they're not there, it compromises their ability to do the right thing, and it compromises patient safety. So that's my sense of it. It's that the whole broader, have we got the organisation, have we got the systems right to deliver the safe care?
That's interesting. And of course, if you're the patient, then safety is something quite personal to you, of course, as well, isn't it? In as much as you can have ostensibly a really great clinical outcome, but the whole experience is totally traumatic in the environment, in terms of the fact you were fearful, or people didn't explain things, or you witnessed behaviours which were errant, and you came away from the experience technically mended, but psychologically scarred.
Absolutely. And I think, this is the kind of relationship between the patient and indeed the wider community and healthcare providers. Have you got trust and confidence? We've been doing some work with Great Ormond Street Hospital, who are really very, very committed to the broader safety system agenda. But, they've been asking the children and young people, do you feel safe? What makes you feel safe? And it is very personal, because it is about getting the right, it's those intangible emotional things, but they are informed by, have you had the right information? Has someone listened to you? When they've been listening to you, have they acted on that? And I think that's why, if something goes wrong, that absolute sense of betrayal that my family, many of us have felt, where something has gone wrong, and then you find out, which is traumatic enough, and then you find out that's actually happened in that organisation before. And unfortunately, if you get the platitudes, well, we're learning from this, you think, well, you didn't learn before, and someone I deeply care for has been harmed by that. How confident am I that you're taking this seriously? So deeply, deeply important matters of trust and confidence in healthcare, which is not just about trusting your individual clinician. You can do that, but if they haven't got the conditions to support them.
I think that really is interesting, then, thinking about your career. And you talked about that kind of seminal moment where you thought, actually, I've seen something here. And particularly with To Err Is Human. We were, Darren and I were in Melbourne back this time last year, I think, actually, at the BMJ Quality Conference. And Don Berwick stood up and asked everybody in the room a question about why 30 years on, why are we still not learning from, in the way that he would have envisaged everyone learning? Why is it not learning cultures? Why have we really done enough? And I think just to get your reflections in terms of that, and, and even the question you've asked, Darren, which is, there's still a question about what patient safety is to different constituent groups. So what's your sense, Helen? What's your sense about what's gone really well in that 30 years and perhaps where have we got work to do?
Predates me by quite a lot. I had the pleasure of actually being in meetings with Don was when Sir Liam set up the World Alliance for Patient Safety that became the WHO programme on patient safety. He set up an expert group to kind of scope what was needed and to inform and engage and advise that programme as it developed. And Don was one of those. So along with people like Peter Pronovost and James Reason, I mean, it was a, pinch me for sitting in the room and being able to contribute in a little way to some of those discussions. But I think my sense is we thought we'd have done it by now. we thought that what was being described by us as human organisational was so self-evidently true that we needed a transformation in healthcare to put, as we say at Patient Safety Learning, patient safety at the core of healthcare. It's not one priority of many that you can juggle around as like, oh no, we need to get access targets and waiting lists down and we need to sort out the money and safety will look after itself. Well, it doesn't. I mean, you have to drive for it. You have to know it. And so sort of two reflections, I think. One is something that Donna said separately, which is over the years, patient safety seems to have, in its practical application anyway, moved from this is something we need to do as a system, as organisations with the right leadership and culture, we really need to drive it. And it's kind of moved increasingly, sadly, into a series of programs. So rather rudely, I call it initiativitis, which is a number of activities which are good, but they are kind of clinical safety focus. But actually, who's addressing the big picture? And so you've got national, I mean, we work sort of globally, but particularly with the NHS in the UK, and especially so in England. And you see the national strategy and its ambition is to get underneath the skin and try and address culture sort of leadership and give people the tools to do that. But I'm concerned, and patient safety learning concerned, that's very much a message that's going out through the patient safety community, and we all agree with that. But is it really touching the sides on the kind of leadership and leadership priorities? And so I was going to say two things, but now I'm going to say another two things. One was that's kind of why when we set up patient safety learning, we produced a report called the Blueprint for Action. And what we tried to do in that report was to answer the question, well, why is harm persistent? If we know so much more than we did, and we've got people very committed, we've got greater numbers of people working in patient safety, a much better understanding of human factors, not just as how people work together, but actually in terms of user-centered design and ergonomics more broadly. We've got much better knowledge than that. So why isn't that being applied? And we reflected in our Blueprint for Action, which is kind of main policy framework for what we do. There are a number of foundations for safer care that we have to design in, and they are around leadership, culture, having the right data and insight, engaging patients if things go wrong, in improvements at the point of care, and sharing learning from good stuff, from bad stuff. They are issues around organisational effectiveness as much as the kind of clinical safety. And then we've been developing, the last point before I pause, that we've been looking at, well, why those being implemented. And we did produce a report a bit ago called Mind the Implementation Gap, which looked certainly from a predominantly England focus, even predating mid-staffs, why we've got these series of inquiries with well-researched evidence, with clear conclusions and recommendations, and why as a system aren't we good at implementing those? Because we haven't got the response to those that we need. I was reading this morning CQC's report on Nottingham and the tragedies there for how people with complex mental health needs are supported and the challenges in supporting that and the tragic implications of people that then go on to commit crimes and how those can be prevented. These are difficult issues, but the CQC report was highlighting where it had made recommendations in this in the past. You want to move from recommendations to action and implementation, and that's very challenging when you've got, the scale of issues in healthcare at the moment around resourcing and staff workforce burnout, capacity, very difficult. But we do have to put safety front and centre, has to be a core purpose.
There's so much in what you say there. I'm just reflecting as you were talking there. Back in my NHS career, I went through any number of leadership programs, development programs, board development and junior leadership development programs. Some were national, some were local, some were commercial, some were public sector. And within all those programs, there was very little narrative around safety. There were lots of tools and tricks around getting on with other colleagues and such stuff, but not much around safety. And I wondered to what degree, two questions from me at this, well, probably three, but I'll make it two. So what's your view on the gap? You mentioned implementation gap. To what degree does the gap reflect lack of proper development and training for senior staff in the NHS or any other public sector service? And secondly, is it an issue of money in patient safety? Is the money the problem? Is it development of the staff? And my last point I was going to make was, from my early days in clinical service, when technology was sort of a byline, it wasn't really there. We managed everything on sheets of paper and it was fine. To what degree does the implementation of technology in healthcare affect patients? Where do we stand around the impact of technology and safety? But my primary initial question was, is it an issue of development of the workforce in terms of safety culture, safety awareness? You mentioned initiativitis, and I've been a victim of that myself. Every time we had, in my NHS career, every time a report came in describing some new calamity at another hospital or another unit or another system, a programme of work was put in to address all the recommendations of that report and tick them off. We'd addressed, at least considered, and hopefully met and could evidence that we'd done work to make sure that that wasn't an issue where I was. Then my reflections there, Helen, about the role of proper board development and individual leadership development and putting safety front line and centre of that development programme. I never experienced that.
It's shocking and it's surprising. And so increasingly, I think it's a bit more porous with working with other industries. And there's a lot talked about, we can't just, it's not aviation again, but how those industries think about safety and risk is very different. And I've got a colleague of mine is a human factors forensic investigator, and we're beginning to work with him in healthcare. He was brought in to have a discussion with the chief exec of a big petrochemical company in the US. And I think his company, they make a bit of money because they're very experienced. And the chief exec said, isn't this going to be very expensive? And the director who had brought my colleague in said, well, yes, but, kind of thing. But if you're not able to evidence that you took the right action knowingly, then the fine will be 10% of your turnover, not 10% of the profits, 10% of your turnover. That's the fine the regulators will impose on you. Do you think my fee is okay now? Yeah, thanks very much. So it's a bit of a trite example, but it shows that those industries put safety at the core. And there's lots of discussions around safety management systems. And, HSIB have recently done a report on that. I helped convene and chair a conference, HIMSS in Rome recently on safety management systems. We're about to write that up. So I think there's lots of interesting reflections about how you build an industry that brings all those parties together. So you've not got these kind of silos. But in answering your question, I think, yes, if you go on leadership, and I went on lots of leadership development courses, became a director when I was 30, and I didn't know anything about patient safety. I think the presumption then, and I think it has changed now, is that, you don't have to worry about clinicians sort that out. And of course, there's a big gap because clinicians do their bit. Organisations, leadership, I felt in my career, really good people that I worked with, they were managing the organisation and they were managing relationship with their stakeholders and were managing upward. Yeah. And the safety bit kind of got missed in the middle. So there is an increasing understanding, and the National Safety Strategy, Patient Safety Strategy has got, curriculum development and requirements for people to understand patient safety and human factors. I don't think it's enough, but it's something and it's a good progress. But that whole cultural issue that you've kind of mentioned is very much an assurance framework. Yeah. So it's kind of, this could happen to us. Can you tell us that it won't? And so, one of the ways that we talk about in our Blueprint for Action is about the importance of professionalising patient safety. And we mean that by taking those approaches from other industries and other healthcare systems that do this. And we're very strongly of the view that you need a standards framework for patient safety. Organisations need to know what good looks like for patient safety across each of these foundations. And if you don't know what good looks like, you can't assess where you are against that. You can't develop your improvement journey. And you're just then, without that, you're responding to, the latest challenge that comes across your desk, whether that's delivering PSERF, LFPSC and other initiatives, or whether it's looking at what's happening in Nottingham and going, could that happen to us? And you're always responding in a reactive way. Whereas I think our approach is, as a board and as senior leaders in organisations, clinical and other leaders, you should know what your safety risks are as an organisation, patient safety risks and other risks, and that you should know where your strengths are, celebrate those, build on those, share your good practices with others. But where there are gaps, you should be designing those into your organisational strategy. So PSURF is an organisational development intervention. You should be bringing the whole organisation with you on that, rather than where we see in some places it's being implemented by a patient safety team. The rest of the organisation doesn't understand it. It is that whole core leadership agenda, I think. And I haven't yet, you mentioned about money. So one of the things, OECD have done quite a lot of work on this at a system level, and number of reports, they're very good. And the first one, there's ones in primary care as well, but the first one looked and said that in the developed world, you're looking at between 12 and 15% of all healthcare spend is as a direct consequence of unsafe care. Now, we know the billions that are being spent on clinical negligence. Those costs are easy to quantify. What isn't so easy to quantify is, well, what's the increasing length of, apart from the, moral, what about apart from the morality, the tragedies of unsafe care, but we're wasting money by doing the wrong thing. And, so many patient safety colleagues and through the networks we support say, we haven't got money for patient safety, but we're wasting it doing the wrong thing. So we need to have a kind of, a business case approach that says when we're looking at organisational and system productivity, we've got to put patient safety in as part of that. So we've got some really interesting potential collaborations with some NHS organisations and others. We're shaping proposal to do more work in this area, because I think internationally there isn't enough looking at what are the financial consequences and how can we turn the dial and actually invest for safer and more productive and effective care.
Yeah, and it's something, Darren, I've got a question for you then related to that, because we're obviously in the middle of an initiative around productivity and efficiency, core part of what the workforce software in particular can deliver to an organisation. And if done badly, is a pretty bad experience for the people at the end of it, and almost certainly can be done without any thought towards patient safety. So we say that we're anchoring that in patient safety because that's why we're a patient safety company and not a workforce company. What's your reflection when you hear Helen talk about that business case and whether or not we, are there productivity offers that should be around the safety agenda? Investments that could be made that actually save money ultimately.
You'd like to think so, wouldn't you? At the end of the day, it's really interesting, the productivity narrative, because a lot of this isn't new, but it's been repackaged latterly. I always see these things as an opportunity to refresh the thinking. So, reductively on the face of it, productivity is around, beans in, beans out. You can make it very reductive, very simplistic and totally inappropriate for healthcare, where you've got human beings involved in the production line, for want of a better expression, which is very different to the manufacturing processes. But it does give you an opportunity to revisit what we're talking about in a deeper sense. So although productivity is, you would like to think that productivity has got safety baked into it in the assumptions that everything that we're talking around about improving efficiency of rostering or job planning or whatever you care to mention has got an assumption that safety is key. Well, we know from what Helen's told us and the reports that have been written that isn't the case. We've got lots of work to do to make sure that those assumptions are sound. But what productivity does give us the opportunity to do is to think about wider issues and weave safety back into the narrative. So you're right, the work we've been doing recently around productivity has been looking at, one of my personal interests is around pathway productivity and using technology across clinical pathways, be they elective care or non-elective care, and thinking how technology touches those pathways and how we can make them more productive. And if we make them more productive in the right ethical approach, then we'll make them safer, because as you've just mentioned, Helen, there's lots of, never mind the moral aspects, there's lots of financial consequences for rework and redoing things that weren't quite right the first time. Despite the fact that it's financially unattractive, it's also for the patients extremely unattractive to be brought back into hospital, to have things done to them that should have been done better the first time around. So for me, if nothing else, the productivity discussions and the narrative now gives us an opportunity to revisit all those assumptions and to challenge them, which is why I think on the face of it, it's an efficiency drive. It's all around financial health, but it's actually around safety.
Couldn't agree more. And we did a report last year called Elephant in the Room. And the elephant in the room in regard to the specifics was about the role of ICBs and ICSs and what a fantastic opportunity to actually look across organisational boundaries. And we know transitions of care are a big patient safety risk, whether it's transitions within an organisation, across organisations. You only need to listen to Adrian Ball and Royal College of Emergency medicine and the challenges there. I'm looking at sort of emergency care, but the transition, the patient pathways, I mean, those issues have to be grabbed at a system level. In individual organisations that can't address that, whether you're an ambulance trust, whether you're a GP practice, whether you're a secondary care trust, whether you're a tertiary care, and then the whole social care environment as well. It has to be whole system. My view, and I've not worked at an operational level, but our sense is, care pathway approach is right. And there's more to be done, clearly. But if you look at the massive improvements in cancer care, a lot of those were driven by it being patient-focused, care pathway-focused. And, there's lots of lessons from some of those specialty-driven approaches and networks. And I think we could learn from that and develop those. And I think it's an underinvested resource, and they've got real challenges in terms of money at ICBs. But the opportunity for ICBs to coordinate this so that you've got that population perspective and the care pathway perspective with, on some areas, the national leadership. I see some fantastic work that the now renamed HIMSS are doing. The patient safety collaboratives, they're doing some great work at a delivery level, but that kind of model needs to be scaled up, I think.
So I'm just wondering what your reflections are in terms of how that, and particularly thinking about other industries actually, how do you make it genuinely everybody's business and not something that belongs to the expert group, which sometimes, where you get great teams can be really engaging, and where you get teams that are not in the office anymore can be really remote. Just any reflections you've got there, Helen?
Yeah, but the conversation is, how well do you know your risk profile? What are you doing about it? How are you celebrating good? Are you taking the right approach to delivering improvements? And regulators can make that judgment, but it's informed by the organisation owning it.
Yeah. That's a really nice segue to the report that you've just released in the last sort of week or so around the EPRs. I know you mentioned it briefly earlier on, but I think it'd be really useful for listeners to understand a little bit more about this. I think for a long time, there's been some fairly high profile failures in EPRs. Anecdotally, there's plenty of stories on week one of when these things go live and the implications it can have in terms of patient records and access. And that's then before we get to the longer term fatigue, actually, that colleagues can have by just trying to navigate the systems. And yet we know that they're designed to do the opposite. So this report is really interesting because it kind of exposes all of that and gives some pointers in terms of what people should be looking at. And just your reflections from your roundtable where people opened up about it would be really useful, I think.
It was a really interesting piece of work. We hadn't got this in our business plan for this year. There was another example, and I won't go into the detail of it, but Clive Flashman, our Chief Digital Officer, and ourselves were talking about this issue and having a bit of a mini rant, actually. And I sort of said, well, just write a blog about it then. And so he did. And then that generated a lot of interest. And we thought, hang on, there's a lot of people contacting us saying, this is quite a big issue and we don't know how big it is, but this really is a safety issue. Then the more we researched it, there is evidence. And clearly coroners are clocking this now and are exposing it. BBC have done some work on it. So the more we looked at it, the more we thought, EPRs are part of the safety solution. They are a great thing, but you need to implement this. So we were focusing not on the actual design of the EPR systems. We're assuming that they're designed for safety and that's their intent, but how they were implemented. We thought, well, we ought to do some work on this. It would be useful to have a round table of people in a psychologically safe space, people that are chief information officers, people that work in the industry as consultants and advisors, having come from the NHS, some clinical safety officers, technology experts, and everyone saying, do we have a problem here? And if we do, what are the problems and what do we need to do? And so that discussion drew, again, more evidence of there being a problem. And one of the things that might interest you is in terms of reporting systems, we came up with 10 principles for how we might make EPR implementation safer, or how organisations would do that. We wouldn't do it, but, best practice recommendations. And one of them is about kind of capturing where it does impact on safety. It's not something that I think information systems or, the LFPSC identifies it. And when people are doing, if we mentioned about PSERF, if people are understanding the contributory factors, they will be looking at things not just the staff involved in an incident, but they'll be looking at underlying contributing factors and, technology or the misapplication of technology or the poor design implementation might be a factor of that. And you would ideally want people trained in investigation to better understand those issues so that they're aware of them and can think about them. So what we came up with through that report was sort of 10 principles. And I would say, none of them individually are probably surprising to people in the field, but really a kind of strong thing in this podcast is me talking about organisational culture and organisational leadership and responsibility and the EPR implementation. This is such a strong message from that roundtable. It's not a technology project. It's not a technology project. It's an organisational improvement project. You need to redesign or understand how you can redesign your workflows for better practice, how you engage with staff, how you make sure it works for them. So what they're not doing is, when they've been trained 4 months ago and then the system comes in, they're then having to do some workarounds because it doesn't meet their needs. And so the chaos that can ensue is avoidable if we design it properly. So it's kind of shouting out about the potential risks, actual risks in some cases, awareness raising, and what good needs to look like.
Just before Darren comes in, I don't think I've ever come across a software implementation that is a technology project, right? And yet, they're always approached and managed in that way. So Darren, I know we're going to go. You've got direct experience here. Yeah.
I've been bruised by being the SRO for an EPR implementation in my NHS career. It is cathartic. We haven't got time today to go into the full, we'd be here for many weeks. But you're absolutely right. The points you make in the report and what you've just summarised, how you just summarised is absolutely spot on. It is a change management. It isn't application of technology. You're absolutely right. And of course, every EPR implementation is a multi-million-pound piece of work. This is serious stuff. And my reflection always throughout the process, which was very battering and bruising, was the safety elements of this are not to be underestimated. And I think vendors and organisations have both got roles to play in this, is to be absolutely candid around the absolutely huge scale of change management required to make these things implemented successfully and safely. You mentioned training, the resources required to get training done properly and to keep it at the top of people's minds months later. The workflows that have to be attended to, it goes on and on and on. And I think, there's no more powerful example of how you get safety culture right than an EPR implementation.
It's a real opportunity, but I think there's, particularly now when finances are so tight, the temptation would be to invest in getting your capital budgets approved for an EPR implementation. And many organisations already have EPRs, but for the ones that are on this track, the temptation is to, not temptation, but if you don't have the revenue budgets, you don't have the money to fund those, or you can't allocate them, you've got other constraints, that the whole redesign and the staff engagement, the user-centered design, the implementation, the training, that gets lost. And that's a huge risk.
I mean, there's a real example with something we're involved in the US and now actually in this country, which is where the technology fix for the archive data, i.e. you switch the EPR on today and you appear or you present in A&E and are your historic records from yesterday onwards accessible, is a really traditional archive solution traditionally, which means that it's actually an extra bunch of work for a clinician to do to go get that record, as opposed to some of the stuff that we're working on is where it's presented there and then, click of a button, looks and feels like it used to feel because it's centered around the experience that clinician needs, not the way in which a technologist has designed it somewhere else.
And if I could add to that, I mean, one of the contributors to the roundtable was a clinician, but she was there from a patient perspective, and she'd written an unattributable blog about the experience of her clinical records being inaccurate. Yeah. And, that's on the hub, which I will plug again, a free learning platform. So those personal testimonies as sort of work is done, both from a clinical patient safety and patient perspective, and almost frankly, impossibility of getting those records corrected, particularly because those records, some of them were in primary care and how they were being transmitted to secondary care. So the whole kind of patient angle of it is probably poorly understood. we've been approached by the frontline digitalisation team at NHS England, who have been doing some really good work on this. And we're going to be meeting with them, which is fantastic, because I'd like to promote their work if they'll let us. But the roundtable group that met wasn't really aware that that group existed. Yep. And so there's some sort of, how we share learning, how we communicate, how we prioritise this is a management and organisational development issue, I think. So there's more to do. We've also been approached by vendors who we deliberately excluded because we didn't want the kind of, our system can do that. Yeah. And that wasn't what we were looking to do. We weren't, but a number of them have sort of said, we really welcome the report. Yeah. You're absolutely right. There are things that we can do. So we might be looking to develop a round table with vendors to say, okay, well, what does good look like? Where are the case studies and experiences? And they may already exist, that the NHSC team may already have them, but through our knowledge platform, the Hub, we can actively promote to not just a UK, but a global community. So the more we can share good practice for others to learn from, the better. That's kind of what we're about.
Yeah, absolutely. And there's lots of that good practice with the EPRs globally. And actually in this country, because there's some homegrown systems that doing some fairly interesting stuff around maternity in particular, which obviously is an area that needs extra special focus.
If there's one thing that's more challenging even than putting in an EPR system, it's moving from one EPR system to another EPR system. That's even more challenging.
What Clive did highlight, which was, there are numbers of standards that organisations need and vendors need to adopt. So it's not a standards-free zone at all, but the standards don't really pick up the kind of safety issues that we've highlighted in the way we think they should, either in the standard or in their implementations. There's more work to be done. But one of the areas that Clive highlights, because he's much more knowledgeable about this stuff than I am, which is it's not sufficient to take these into account in your implementation. You need to review that at peers afterwards. So, whether that's 3 months, 6 months, 2 years, 3 years, how's it working? So it's not just about we got it in, we switched it on and it's working. It's like, is it working for us? Is it working for the clinicians? Is it working for the organisation? And then what more might need to be done to kind of tweak and reflect that? And part of that is capturing, if it's not, finding out from clinicians, are you having to do workarounds? And what are the unintended consequences of those? And looking at those from a safety lens, I think is really important.
Really important. So that's definitely a report that we'd encourage everybody to read. It's hot off the press really in the last 7 days, and something we'll probably talk to you about a little bit more over the next few weeks and months. We're getting probably towards the end now, aren't we? We probably have gone a little bit longer than we're meant to, but it's so interesting. I think there's more to talk about, Helen. We might have to do another one. I was going to ask you both actually then, I think we've got a feel for your career, for the work that patient safety learning does. We've talked about a little bit about the current environment around productivity and efficiency and the case for that, and that in the context of, I guess, some of the bigger investments around technology currently around EPR systems, certainly in the UK. If you could do one thing or encourage people to do one thing to make patient safety the absolute anchor of how they go to work every day, what would it be? That's my one question. My second question is, if you were now talking to somebody who was thinking about a career in patient safety, what would you say to them, Helen? I'm going to come to you as well, Darren, on that one. Right. I don't know why I went close to my microphone. Yeah.
Very quickly, I probably heard me say this before. For me, in terms of the narrative of, and forgive me if I've not quite got the question right, but the first point here is we've got to encourage young people in colleges, universities, higher education who are aspiring to careers in healthcare, that they are great careers to have, and to celebrate that patient safety is a positive and rewarding thing to be involved in. And it's not an irritant or something at the side. And the more we can do to encourage conversation around the lived experience of being a patient and the lived experience of young people coming into health and care, we've got to have the conversations around safety from the get-go. And that, to me, is part of making it a more joyful career. And I've forgotten what your second question is.
Second question is the most important intervention to make sure that everything's anchored in safety.
Oh, to keep talking about it and to professionalise it. With the roles that Helen's described that I've witnessed going into service myself, is we've got to recognise safety within the structures and methodologies of healthcare as being as important as having a chief exec or a consultant surgeon or a dementia nurse or whatever it is you care to mention. And the roles that need to be in the system around patient safety need to command as much respect and have the same development of a career pathway with aspirations and talent management and progression as any other role in healthcare. So we've got work to do on that. I think that is my reflection on that issue.
Well, I won't answer that because you've been given a perfect answer for that. Absolutely. It's about professionalising patient safety across the organisation, but those people that are working in it. And I think, everyone can bring something to it. So I think more people that have got a clinical background in patient safety is fantastic. Non-clinical people too, who've got governance, risk understanding. It's bringing that kind of a multidisciplinary team perspective to it. So I would reinforce everything you say. In terms of one thing, I'm not going to do one thing. I'm going to say two things. So I'm going to look at, it's kind of top down, bottom up. So I would say the top down thing is that organisational leaders need to embrace patient safety in the way they don't at the moment. Some do. There's a lot of rhetoric and there's a sort of, we've learned from this, and then you delegate it down to someone else. You want to see boards and systems putting safety at the core and not just another priority to be managed. And then the bottom up is listen. Listen to staff, patients. They know the issues. They know the work is done. Human factors people talk about, work as imagined, work as prescribed, and work as done. What is absolutely fantastic about these networks that we support is people are sharing in a safe, psychologically safe place the kind of work is done, the challenges, what needs to be done, how people are addressing it, sharing learning, creating networks outside of those meetings to share good practice. Really embrace and get your front line, whether that's patient safety partners. I think a fantastic opportunity to embrace that system thinking engagement and the patient perspective, as well as, frontline clinicians and safety managers. Listen, there's a lot to be learned from them.
I love that. So in summary of everything, I've just said, first of all, if you're going to create technology, build with patient safety in mind. Talk about patient safety everywhere, at every level. Don't outsource it. It's not outsourceable. Is that a word? I'm not sure. And then the one that I love is listen. Keep listening to everybody. So I think that's
and act on that.
An act. Absolutely. Well said, Helen. Yeah, that's great. Well, thank you so much for joining us. And if you don't mind, we'll ask you back again, maybe on a different part of the topic.
Yeah, there's loads to talk about.
Great. Okay, lovely. And for those that don't know, we've talked a little bit about the hub. We'll offer links so people can go visit that because it's free for people to join, access an incredible amount of resources. It's unique.
Over 20,000 resources on there now. You can access the networks. That's all free. Have a look at the hub. And then if we can also put on the link to our work and thinking on safety standards as well, I'd like to push that.
Yeah, absolutely love to. Thank you, Darren, and thank you, Helen.
Thank you for joining us on today's episode of The Connection. We hope this episode has provided you with valuable insights on the role that both technology and people play within the healthcare landscape. For more information and resources, visit RLDatix.com. Don't forget to subscribe to The Connection on Apple Podcasts, Spotify, or any other podcast platform you use. Join us next time as we continue to explore how healthcare is impacted by connecting people and technology. On behalf of the RLDatix team, thanks for listening.